Oh, there it is. Got it. Well, welcome everybody to another rouse.
I just muted you by mistake.
There we go. I fixed it.
Sorry.
Welcome back to the rendition of asking me questions and I make stuff up that hopefully sounds reasonable. I'm Dr. Leichliter. For those of you who don't know me, although I think most people that generally come here know me, but if you don't, or if this is your first time, welcome to the party. I am Dr. Leichliter. I am a movement disorder specialist at Allegheny Health Network. I do run the Parkinson's clinic that we have, a multidisciplinary Parkinson's disease clinic here. And this is a fun time to ask me questions and I will answer them to the best of my abilities. The general rules of thumb I like to throw out are this is not a great place to ask for specific treatment. So, it's not a great place to ask, hey, I've had Parkinson's disease for this and this, I'm on this, what do you think I should take next? That's great. That's a great discussion for you and your doctor, which you should have. And realistically, you should have a neurologist if you don't. And realistically, you should probably have a movement disorder specialist neurologist if you don't. I might be a little bit partial on that one because I am one, but I think we do it better. The other rule of thumb I like to throw out is everything you hear is my opinion. And so, movement disorder specialists do vary in their opinions. So you might come to me, I give you one opinion, you go to somebody else, they may give you a different opinion. So you just have to take my opinion for what it's worth. Generally, I try to give you the best information that I have. Theoretically, that is evidence-based, and sometimes I do make stuff up. If I'm going to make stuff up, I'll usually let you know. I'll throw up some air quotes and tell you that I am making stuff up. There were a couple of questions that were emailed to me, so I'll start with those ones first. If you do have questions, though, put them in the chat box. There's a chat button that has a little kind of balloon that would have like a cartoon talk in it, and you click on that button, you can type it over on the side, and I'll get to it in a minute. The first question I got was, what is fascination and how many ways does it apply to Parkinson's disease? So generally we think about fascination in terms of walking. So the gait that people with Parkinson's disease have is called a fascinating gait. So that short shuffling steps, that kind of getting stuck in like your feet are trying to move, but you can't move. That's what we term fascination. It's a part of Parkinson's disease. It comes along with the whole process. You can also have fascination in thought, where, you kind of stutter on thinking and difficulty in getting things out. But usually when we think about fascination, it's a manifestation of the walking and the gait. Excuse me. It's also one of the more difficult problems to try to fix. Again, much like all the walking and balance problems are difficult to fix with medicines. It is one of those things that I do refer to a lot of physical therapy for, learning how to initiate that step as opposed to getting stuck or having freezing, taking big steps, lengthening your stride. These are all things that can be worked on mainly through therapy. And that's usually the best way to try to work on them. But that's usually what we think about in terms of what we call fascination. Am I treating any Parkinson's disease patients with the Ymca protocol, high-dose vitamin D, or the high-dose thiamine protocol as prescribed in Italy? The short answer to that first question is no, but I will get to what each of these are and, period. Do I know of any doctors in Pittsburgh that are offering either of these treatments? And again, the short answer is no. And so the main crux of this question is, so there are a couple of protocols that were come up with or that have been studied or that have been looked at. One was by, hold on, I already looked this up. That's how I had his name. Dr. Cicero Coimbra. And David, my Italian's terrible, so you're probably better at telling me what his name really is.
Let me get the app, and then you can say that.
Yeah, well, actually, I take it back. He's not Italian. He was down in Brazil. So the next people were Italian. So this guy came up with the idea that high doses of vitamin D might be helpful for particularly, I think he started in MS, was looking at autoimmune conditions and stumbled across Parkinson's disease. And so I actually went to his website to look and see what they were doing, and they were doing something like 40,000 to 300,000 units of vitamin D. That's a whole ton of vitamin D. But I took that a little bit, and what I couldn't find on the website that I was looking at was really research. And so again, generally when we're recommending things, or so if you come to my office and I recommend something, generally it's based on some sort of research. It's not always great research, don't get me wrong. There is not always the gold standard, double blind, which means the patients and the doctors don't know what you're getting, randomized, which means you might get the drug, you might not, controlled trial. So generally in medicine, we think of that as the gold standard proof or evidence that something works. That's kind of class A evidence. Not a lot of things end up with definitive class A evidence. And so I don't just base my recommendations or what I do in the clinic on only things that have class A evidence or the best gold standard evidence or trials that are available. But I do like to see some research on these things. I like to see studies. I like to see studies in people. I like to see reproducible studies or something that maybe other people have done that suggests, yes, this is useful. So when medicines have to get approved through the FDA, they have to produce some of this research. They have to prove to the FDA that it works. And they do that by doing these randomized controlled trials. The same thing is true for the deep brain stimulator or surgical interventions, or just about everything that is approved by the FDA goes through this trial process. And so I tried to go look up his protocol and the high vitamin D, and I couldn't find anything. So I went to PubMed, which is where we usually kind of look things up for journal articles or for research studies. And I found no reports for the use of high doses of vitamin D in Parkinson's disease. And so I do question whether or not there's any actual evidence or research to back it up, other than what he's doing down in Brazil. Now, much like I will tell you for supplements or vitamins or other over-the-counter things, is you don't always get studies or good evidence or things like that for a lot of these things. Again, studies and research really costs a ton of money. I think the latest I've heard is that it costs $1 billion, billion with a B, to get a drug from bench to market. And, again, this is also why new drugs cost an arm and a leg, because the drug company wants to recoup some of that money. But the short reason why that's important is nobody's going to spend $1 billion to do a drug trial on vitamin D, right? They're not going to make any money on that. And unfortunately, healthcare is still the biggest business in this country. And so if they're not going to make money on it, they're not going to do it. And so just because something doesn't have definitive data behind it, doesn't mean it doesn't work. It just means that nobody's done the trials. But I couldn't find anything scientific, I won't even say scientific, anything published in journals to suggest that high dose vitamin D helps people with Parkinson's disease. There is some data or some literature in MS for vitamin D, but I couldn't find any in Parkinson's disease. Moving on to the next one, which was the high dose thiamine talk. So again, this is another thing that this was a group in Italy that was doing research and studies on high doses of thiamine to see if that would also help slow down Parkinson's disease. And this one I did actually find 5 papers or 5 articles. Now, they were all written by the same guy. So this Constantini, who is an Italian doctor who was coming up and piloting all this stuff. And so there was actually some published data, although, again, anytime I see data published all by one group, not to say it's bad or it's wrong or it doesn't work, it's just you like to see something that's reproducible. You like to see other groups take that on and then study it or try it and then say, hey, yeah, we did this and it also worked, or publish another paper on it. And so again, my opinion on these things is that they're not bad ideas and maybe they do have some benefit, but at this point, I don't have enough evidence to say, yes, this is a great idea, everybody should do it. There is some science behind these things. I mean, again, a lot of vitamin D is a great antioxidant or free radical scavenger. Thiamine is used in a whole bunch of different processes in their nervous system, in the brain. And so there's some logic behind this stuff, but there's not enough, definitive answers for me to start throwing people on really high doses of these things. Now, on the one hand, generally we think of vitamins or these kind of supplements as fairly safe. But on the other hand, we don't really know what happens when you start giving heavier mega doses of these things. And so I would, and this is just my opinion, I would wait until we see more definitive studies or evidence or some more collaborative or corroborative evidence to suggest they work before I start recommending it or before we start figuring out how to get it. I don't know of anybody in Pittsburgh that's doing it again, but I also don't know what the UPMC guys do. Again, not that I don't like those guys. I like all of those guys, but we just don't work necessarily all that close together. We don't communicate all that well. So I'm not sure if they're doing any of those things or if they're looking at any of those things. I can tell you I'm not necessarily right now, and I haven't heard Dr. Baser is either, or Dr. Flaherty for that matter. So the Allegheny Health Network people, I haven't heard that we're doing any of that stuff. And that's kind of the end of that story. Please talk about the Parkinson's mask, including what the trained eye of a movement disorder specialist sees that an ordinary person does not. Well, I think I see everything. But I could be wrong about that. I think my observational skills are probably better than average, since that's what I get paid for. When you live in a world where there's not a lot of definitive tests and there's not a lot of definitive fixes, you really get paid for your observational skills. And that's kind of what I do. I get paid for watching people. And so I do think I pick up things, subtler things that maybe your average person wouldn't notice. And the facial masking is actually one of them. So what we mean by that is, people with Parkinson's disease appear to have a masked face, meaning they don't blink as much as normal people. They don't, as much or clear their throat as much. They often sit with their mouth open as opposed to closed. And believe it or not, I actually just had this conversation with a patient today. I've read a few of Michael J. Fox's books. And in one of his books, he's not my patient, by the way. In one of his books, he made the comment, he was still working when he was diagnosed with Parkinson's disease. And I guess on set, everybody he was working with would go to the producer or go to his person and say, is he mad at me? Because he wasn't smiling, or he didn't have the same facial expression. Everybody thought he was mad at them. And the same thing was true for my patient today. She said my granddaughter, I think it was granddaughter, who was very attentive, asks her, are you mad at me? And that comes back to the fact that you really have to think to smile or to have facial expressions, or things like that. And so that's usually what we mean by the Parkinson's disease mask or the facial masking. And believe it or not, that's not something that's easily noticeable by people who see you all the time. That is more noticeable for people who only see you periodically. And I do think that's something that I pick up on better than, say, that your average person does. The other things that I tend to pick up on, as opposed to kind of an innocent bystander or an innocent person observing, are walking changes. So I think I'm particularly good at picking up shuffling. I'm picking up decreased arm swing, which most people don't notice, flexed posture, difficulty with turning, just kind of walking in general. So walking is something that as a neurologist, we pay a lot of attention to, because you can pick up a lot of subtle changes or findings that maybe aren't noticed by you or your significant other or your kids or somebody on the street. And they do give us a lot of information into what we think is causing it. And so again, those are probably the areas that I tend to pick up more than other people do. Does that mean I pick up everything? No. Am I really all that fantastic at seeing things that ordinary people don't? I don't know, maybe. But maybe there is something to it. And you just have to put up with my cough because it comes with the rest of me. Sometimes a patient with Parkinson's disease says they were diagnosed with Parkinson's after the death of their spouse. Do strong emotions amplify Parkinson's symptoms or accelerate progression? So I thought that was an interesting question, because I don't know that I've ever heard that. Although in thinking about it, it does make some sense. So I do hear of people saying, you know what, I woke up from surgery with Parkinson's disease, or I had an illness and then I got Parkinson's disease, or I had an accident, a motor vehicle accident, or a fall, and that led to Parkinson's disease. And so at the end of the day, the way that I view these things is not necessarily that those things caused the Parkinson's disease or that the death of a spouse caused Parkinson's disease. But my guess is you were probably already on edge, or these patients were probably already on edge, and that just tipped them over into it. So we know through studies, you don't really manifest symptoms of Parkinson's disease, outward expression of Parkinson's disease, until you've lost 70 to 80% of dopamine making cells. So you really are already progressing in the disease before you even notice symptoms. Now that's a big problem, because that's part of the reason why we have such a trouble in fixing it or coming up with a solution for it. But that's a different type of question. But because you've already been in the process of developing Parkinson's disease for probably a long time, it's not overly surprising that if you had something that knocked off a few extra cells or took out a certain more percentage of these dopamine producing cells, that it could lead to manifesting Parkinson's disease. And we know general anesthesia does that. It wouldn't be a surprise if an accident or an injury did that. And I would venture to bet that a very, very stressful situation could also put enough oxidative stress or energy stress or some sort of cellular stress on these areas of the brain that are already friable or susceptible to more damage, and that could tip you over. So the short answer to that question is I don't know that I've ever heard that per se. I can't think of, and my memory isn't as good as yours either, but I can't remember anybody necessarily coming to me and saying that specifically. But I wouldn't be surprised by that, because I do think that things like that could trigger just that last step to push you over into physically manifesting the disease. And I thought this last question that I got in email was actually useful for kind of a broader topic. But so as someone with an early diagnosis, this person is 52, I'd like to hear about what to expect in the early stages, what symptoms or changes to look out for, when to start medicine, how long this treatment might be effective, pros and cons, what might be alternatives or changes down the road. So basically this is, give me the idea of what Parkinson's disease is from start to finish. That's how I interpret this question, which of course I could spend hours talking about, but I'm not going to, because David would absolutely fall asleep if I did. Because I'm the only one who finds this stuff interesting enough to talk for hours about it. The short answer is, and I'm going to start with kind of symptoms, treatment, progression, end result. You get diagnosed based on symptoms, mainly the motor symptoms, the tremor, the stiffness, the slowness of movement, the balance problems. It's also, and we know is also associated with a whole host of non-motor symptoms, anxiety and depression, sleep problems, bowel problems, you name it, urological problems, so on and so forth. After you get the diagnosis, then it comes down to management. So what can you do early on? Well, we all know the answer to that question, because my absolute favorite thing to talk about is exercise. And that's what I always talk about first, because exercise is the most important thing you can do from start to finish. Exercise is the only thing that we think can slow down disease progression to keep you better longer. This is why it's so important to, again, especially for people who haven't been traditional exercisers throughout their life, it is best to start as soon as possible. Now, obviously, it's better if you've been somebody who's been exercising your whole life, but if not, no better time to start than now. So as soon as you get a diagnosis, then exercise really has to become a mainstay of your life, because it really is the thing that gives you the best chance to have long-term success. And I can't stress this enough. I know my patients get tired of hearing it. David certainly gets tired of hearing it, because I talk about exercise out the wazoo, but it is so important for long-term success. All else aside, I can tell you in my own experience that the patients who exercise the most do the best. The patients who exercise the least do the worst, period. Everything else aside, medications aside, other comorbidities aside, exercise really is important for long-term success. So if you're a young onset person or a new diagnosis person, especially if you're somebody who has not been traditionally active, now is the best time to find something you enjoy doing that's active, that gets you up, that gets you moving, that keeps you moving. It is the key to success. The next question is when do you need medicine? This is a question that I have every day, all the time in my office. When's the right time to take medicine? Do I need medicine? What's the right medicine? And that has about 1,000 different answers. My philosophy is none of the medications that we have, carbidopa, levodopa to everything else, none of these medicines are disease modifying. And what that means is none of them keep you better longer. None of them slow down disease progression. None of them actually impact the underlying brain condition, which is loss of dopamine cells. All of the medicines that we have are symptom management. And the way to think about this is the medications treat your symptoms. Exercise actually treats the disease. So again, this is why it's so important. But the reason why that's important from a medication standpoint is in my opinion, there's really no harm in waiting. Now, yes, you can wait too long. If you wait too long and you're disabled by your symptoms and it's causing you pain or you're falling, well, then yes, we did wait too long and we missed an opportunity to help you do better. But especially early on, there's not a risk to waiting to take medication until your symptoms really are bothering you. And the way that I define bothering you is, are they impacting your day-to-day life? Are they keeping you from doing things? Are they keeping you from doing things you like, want, or need to do? In other words, are they disabling you in any way, shape, or form? If the answer to those questions is yes, then it doesn't make sense to just ignore them. It makes sense to try some medicine. Now, actually, in our main journal, the green journal, the American Academy of Neurology journal, there was actually just a recent outline of starting treatment for people with Parkinson's disease, and almost resounding or almost across the board, carbidopa, levodopa is the best medicine to start with. There are actually very few indications, which we knew and we've been doing, but even just kind of brought up again in this paper, there's very few reasons you wouldn't start with Sinemet. Does it have side effects? Of course it does. We do not have a side effect-free medicine. Are there potential complications in terms of motor fluctuations or ups and downs throughout the day, hallucinations, dyskinesias? Absolutely. Am I aware of all of these problems? Yes, I am. Does that mean I shouldn't start this medicine? No, it does not. Even though we know there are problems with the medicines, there is no such thing as a side effect-free medicine. There's no such thing as free magic. In terms of quality of life, or benefit or improvement of symptoms, there is no better medicine than levodopa. And so now almost across the board, and we've gone up and down, we've gone around in circle in this over the past 20, 30 years in terms of which medicine we start with, when do we add what? We've gone full circle probably 3 or 4 times in what's the best medicines to start. And there's still different people who have different philosophies. So I should say this is a lot of my opinion, although it's based on a lot of reports. Carbidopa, levodopa is almost always the first medicine we start with. And then we add medicines to it. So, it's not uncommon for my patients to end up on several different medicines because they all work together. They work in different fashions, but they kind of complement each other in terms of working for your benefit. And then as the disease progresses, yes, your symptoms get worse. Yes, you need more medicine. And this is on the order of months and years and things like that. We do have to watch out for side effects. We have to watch out for hallucinations. We have to watch out for a lot of things. And all throughout, you have to be exercising, but then we just kind of watch and see how your disease progresses until eventually you get to the point where, if there is such a thing as end-stage Parkinson's disease, which, this is subjective. Everybody has a different opinion about, does it ever get to a point that we start cutting back medicines or we become less aggressive in our treatments? I don't know. Sometimes we do, sometimes we don't. There's no right answer to that. But that would be something you would think of down the road. But that's kind of what to expect from start to finish. Now, I know I glossed over a whole bunch of things. And again, I could talk about that question for a really long time. But really, the take-home messages are exercise is vitally important, especially early on, but you have to continue it forever. Medications are a little bit more subjective in terms of when you need it and which one to try and how you progress in terms of needing more and more medicine over time. And these are all things that we can talk about in the office as you return, as we see how you do, and as we continue to follow along with you. You know, again, the good part about what I do is, you know, when I get a patient who comes to me, they're pretty much my patient for the rest of their life. I'm almost like a primary care doctor in that fashion. I'm a terrible primary care doctor, though, so don't even start thinking I'm going to be your primary care doctor. That's not going to happen. But I do tend to follow people forever. And so I do get to see how things progress, and we continually work on this from start to finish. All right, let me scroll up to the top here and see what the questions that have come in so far are. Have I seen any success with medical marijuana usage for Parkinson's disease symptoms? Yes. So I've been a certifier of medical marijuana for Parkinson's disease and Huntington's disease and a bunch of other stuff for, I don't know, four or 5 years? No, I can't remember.
Since it was legalized.
And how long has that been?
Yeah, probably four years at least. Yeah.
I can't keep track of this stuff.
Well, and
we'll say
I'm
4
just
years.
Making it up. So.
Hey, that's what I do anyway. We'll say 4 years. Doesn't matter. And so at the end of the day, I've learned a lot about it. There's two different ways to look at success. So one is, does it directly treat Parkinson's disease? And in that regard, I would say I have not had a lot of success. I have not had a lot of direct success with marijuana treating tremors or stiffness or slowness of movement or balance problems. And so I don't think it has a direct impact on, say, the dopamine pathways or the main motor symptoms of Parkinson's disease. However, secondarily, I have had some success, and there's been 3 areas that I think I've had the most success with medical marijuana. So one is pain. Pain is probably the biggest utilizer of marijuana. Marijuana does seem to help with pain. There's literature in opiate use disorder and how that's impacted by using marijuana in its place. And so that actually has a little bit of literature behind it. And so the one area that I think I've had more success than anything is, you know, a lot of my patients do have pain. They have back pain, they have hip pain, they have joint pain, they have pain. And everybody on here knows that if you're in a lot of pain, your physical symptoms are going to be worse. You're going to shake more, you're going to be stiffer, you're going to be slower. And so secondarily, if I can help pain, it tends to help the Parkinson's symptoms. 2 is anxiety. So medical marijuana or cannabis in general tends to help calm people down. Now, not always. Some people it makes more anxious, but for the most part, it tends to be a good anti-anxiety medicine or calm people down. And again, same thing. Everybody here knows that if they're anxious or if they're upset or if they're nervous, they shake more. And so secondarily, if I can calm down anxiety, it does tend to help the motor symptoms. And 3rd is sleep. Again, same idea. If you're not sleeping very well, your symptoms get worse. And so medical marijuana, in my experience, has been good for pain. It's been good for anxiety. It's been good for sleep. And so if I'm recommending it, and I don't usually recommend it, but if somebody asks me about it, I generally look for one of those things in addition to their Parkinson's symptoms to see if that would have any type of benefit or impact. And I've had a lot of people have some success with it. Again, I can only think of one person who ever came back to me and said, this really helped my tremors, or this really helped my Parkinson's disease without one of these other things. I did have one person who did that, who's told me that, but for the most part, it's really been through these other avenues, through these other kind of non-motor symptoms that it's been beneficial for, and then secondarily help the motor symptoms. That's where I've seen it work the best. What was given to the mice that cured Parkinson's? I don't know. What was given to them? Sounds like something good. Let me do a quick look here. Now, I will say, you have to be a little bit careful with these kind of things for a lot of reasons. A single treatment to inhibit PTB. Oh, so this was out at UCSD, University of California, San Diego. Treatments restore normal dopamine level. Here we go. So it looks like out in San Diego, they were working on a new type of proto drug that were able to turn other cells into neurons and thereby basically recreating more dopamine producing cells, kind of like the same thing we've tried to do with stem cells repeatedly, with some success, but some difficulties. So they were infecting the brains of mice with viruses that contain the ability to convert other cells into dopamine producing neurons. That's the long and short of what I just read in 17 seconds. The reason why I always get worried about animal studies is, believe it or not, Parkinson's disease only affects people. As far as I know, there have not been any naturally occurring animal models of Parkinson's disease. All the mouse models, all the cell line models, all the ape models, all the animal models that we've used have been man-created. So we give them MPTP or we give them some other drug that destroys their dopamine producing cells, and we create a model of Parkinson's disease. The problem with that is that it's not natural. And so it's not exactly the same thing that we see in people. And everybody on this call or this talk knows. I mean, how many times have we been burned by something that looks super promising in cell line models, super promising in animal models, even super promising in early on studies, only to be let down come the phase 3 trials where they try it in people, they do a good randomized controlled trial, and it doesn't work. And I think part of that problem is that when we get overly excited about things that happen in mouse models or animal models, it doesn't always extrapolate to people. And so that's at least briefly what I read they were doing out in California for curing mice or curing Parkinson's models in animals. I don't get overly excited in these things until I see them being done in people. And then I think we'll have a much better conversation. I have found that medical cannabis helps me between my medications. And interestingly enough, there's a whole bunch of variety of medical marijuana. And again, same thing. I do think it does help in certain people with certain things, particularly what I mentioned. And you do have to trial and error because there's so many different varieties of marijuana. So I am by no means the marijuana expert. Probably the best expert for marijuana are the pharmacists that are at the dispensaries, unfortunately, because they also have an agenda to sell you marijuana. So there's definitely a conflict of interest there. But they actually, in my experience, have been the most knowledgeable about the different strains, the different ways to get it into you. And I've had patients experiment with different types, and some work better in some people than others. But interestingly enough, I feel like every time somebody comes to me and says, hey, I tried this strain of marijuana, it really helped me, I say, wow, that is great information. And then I go to the next person and I say, hey, I just had a person where this strain really helped them. And then they go get it and they're like, yeah, that didn't do anything for me. I don't know why that keeps happening, but I feel like every time I find a strain that works in one person, it does not work in the next person. I really do think that the idea of medical marijuana, and really the idea of a lot of things, is trial and error. And again, everybody who comes to my office knows that just about everything I do in the office is trial and error. This is the same thing just true for medications. You know, we try a medicine that I think is going to work or give us the best chance of success with hopefully the least chance of causing problems. If it works, great. If it doesn't work, well, then we backtrack and we think of something different. And so the medical marijuana idea is no different. It's a lot of trial and error. It's a lot of, you try something, you see what it works for, what the risks and benefits, you know, what does it benefit, what does it cause, and then you figure out what works best for you. How do low levels of lead affect Parkinson's disease and I assume RLS's restless legs? Again, another thing I'm going to go to the drawing board here for. We do know that there are toxic environmental exposures that lead to Parkinson's disease. I mean, lead could be it looks like, again, UCLA looks like they're leading the studies or the research on lead exposure in Parkinson's disease. Other things that we have kind of better shown have been things like industrial strength pesticides. There's a whole class action suit against, what is it?
Paraquat.
Which is in what?
a number of
But
herbicides.
there's one pesticide that really is in the news. You see, again, I can't remember all this stuff. But at the end of the day, pesticides have been relatively linked to Parkinson's disease fairly consistently. Manganese toxicity has been linked to Parkinson's disease relatively consistently, and Agent Orange. So these three have been fairly well documented environmental exposures to trigger or lead to Parkinson's disease. But it's probably a whole bunch of, you can imagine most of my patients aren't industrial farmers, manganese miners, or in Vietnam. Some are, but not a lot. And so at the end of the day, those aren't the only things that trigger Parkinson's disease. And we definitely think of in terms of why do people get Parkinson's disease or what triggers Parkinson's disease? Is it some combination of genetics and some combination of environmental exposures? And so again, we haven't worked out all the genetics either, and we haven't worked out all the environmental exposures, but lead's probably very well associated with it. And we know that environment plays, or I know environment plays a role just because of the patients that I see. I can't tell you how many times I've seen a patient and they say, 7 other people in the factory that I worked at developed Parkinson's disease. Or I hear all the time, 6 other people on my street have all developed Parkinson's disease. And that seems more than just chance. But again, if there is some sort of environmental trigger, in Pittsburgh, how many plants have we had throughout the years? Steel plants, mills, so on and so forth. Who knows what kind of chemicals were in there? Who knows what that does to the brain? The same thing is true just environmentally. There's a lot of well water, in which case manganese is potentially a culprit, or lead. Radon is big in Pittsburgh. And so at the end of the day, what are these chemicals or what are these toxins doing to the brain? And could they lead to the development of Parkinson's disease? It's quite possible. The more we learn about environmental toxins and how it interacts or how it causes problems, the more we'll have better answers to these questions. The short answer is yeah, we think a lot of these toxic metals or chemicals or neurological toxins do lead to Parkinson's disease or Parkinsonism. We just haven't figured out how to use that. In the ideal world, we do much better environmental conservancy, safety. There's probably a better word for this stuff. But basically, we would take better care of the environment and we wouldn't have to deal with any of these things. But right now, we don't do a very good job of taking care of the environment. And so I think we are stuck dealing with these things. However, I would say that regardless of the underlying cause. So if somebody comes to me and I've diagnosed them with Parkinson's disease or Parkinsonism, it doesn't necessarily matter if it's lead induced or manganese induced or pesticide induced or Agent Orange induced. The treatments are all relatively the same. We have not gotten to the point where we really have figured out precision medicine in Parkinson's disease, which is the goal someday, but we're not there yet in terms of our ability to specifically treat different versions of Parkinsonism differently and better. And so the short answer is yes, it probably does play a role, but right now I don't have a better solution or much that I can do with that in terms of treatment, at least. Interesting. So if you can get 2 half balls with rubber spikes and roll your feet over them for about 5 to 8 minutes, the result is improved balance. Before teaching a dance class, I do this in my enhanced fitness class, walking toe. And actually, interestingly enough, the last movement disorder meeting I went to, which was virtually, was not last year, but the year before, I think. David, my memory is getting really bad. I think I might need a neurologist. But at the end of the day, there was actually a presentation or a poster of exactly that thing and this was somewhere in Europe. There was this device that had spikes on it, and people with Parkinson's disease were putting their foot on it, and it was somehow stimulating the bottom of their foot. And they were finding that people had better balance after utilizing this seemingly, I don't want to say barbaric machine, but it looked like it just had a bunch of spikes on it. So I was a little bit worried. And so I wonder if it's the same idea. Again, I haven't seen that reproduced commercially or any devices like that have been studied or published on. But there was definitely a company that was looking at this in Europe where they were doing exactly that. So there's definitely something about the tactile input into the bottom of the foot that does lead to better balance. I just don't know that I've figured out how to use that to our advantage. I like the idea of having 2 half balls with rubber spikes on them or rolling your feet over them and seeing if that works. That seems like a relatively inexpensive, relatively easy and side effect free way to try to work on balance. So if anybody else wants to try that, please do. And let me know how it goes, because man, if I could work, if I could have my patients work on balance and get better balance, that would help everybody. So I like that idea. And I think there is some science to back up that idea.
There was an article on socks that vibrated, the soles of the feet, and that was also to help improve balance and gait, I guess.
Yeah, I think we need to do some more research on that in terms of what kind of input or stimulation into the bottom of the foot really does lead to that, because I feel like you could develop a fairly inexpensive device to do that. And again, balance is such an important problem in my patients, and you guys know this better than I do. You guys will deal with it. I mean, that's how you get hurt. My patients don't shake their way to the hospital. They fall their way to the hospital. Balance is the most dangerous problem that my patients deal with. And so anything that helps you guys stay upright is key to success in my book. Are you really losing cells, or has the faucet just been turned off? Parkinson's being an electrical problem rather than a bio. I just posed this exact same question to my residents, and they all stared at me like I had 3 heads. Answer the first question. You definitely lose cells. So we can actually stain this. You can slice open a brain of somebody with Parkinson's disease. You can stain it for the cells, and you are definitely losing cells. But is it really a chemical problem? I don't know. Why do I ask that question? Or why did I pose this question to my residents? Because it's an interesting idea. So 60, 70 years ago, they did exactly what I just said. They sliced open people's with Parkinson's disease brain after they died, obviously. We try not to do that on alive people. They stained it, and they found that you were missing a chemical. They actually thought it was melanin, not dopamine, but through some studies, they figured out it was dopamine. But just because we figured out, or we found that you lose dopamine, doesn't mean that that's necessarily the cause. It's just the first thing that we found, right? We also know that the deep brain stimulator works. And I'll tell you that we don't think the deep brain stimulator works by producing more dopamine. We think that it works on abnormal circuits. So we know by recording that you get these circuits that form in your brain that are normally firing in a certain pattern. In patients with Parkinson's disease, are firing at a different frequency. And we think that that's what we correct with the deep brain stimulator that helps the symptoms. So is it an electrical symptom or an electrical problem? And maybe the electrical problem leads to the loss of the cells that make dopamine. And we only found the dopamine problem first because it's a lot easier to stain brain than it is to record from somebody who's alive. Or we also know that alpha-synuclein plays a role here. So this is the protein that abnormally folds and eventually gets compacted into what we know as Lewy bodies, which is part of the pathology of Parkinson's disease and Lewy body disease. And so is it really a protein problem that this misfolding protein clumps together and leads to the abnormal circuitry and the loss of dopamine cells? I don't know. Again, I'm just making stuff up here. And again, we don't really know what came first, what causes what triggers what, but it's an interesting kind of thought game here to figure out, what really is the underlying first problem. Because it would be sure nice to fix the first problem and try to prevent the later problems if we could. And again, just because we found that dopamine was deficient first doesn't mean that that's actually the underlying first problem. Maybe that was just the easiest problem to discover. I don't know. The short answer to your question is I don't know. We have not worked out what is the actual trigger and underlying problem in Parkinson's disease, or first problem in Parkinson's disease. But I think that actually gets to how do we fix it and how do we correct it, or how do we even prevent it if we can start to figure out the answer to those questions. Great question. Good. Don't ever get tired of hearing me talk about exercise, because I'm never going to get tired of talking about exercise. My PCP told me a bunch of times that within 15 years of my diagnosis, I'll have dementia. This is from a guy who couldn't diagnose my Parkinson's after seeing me for 30. That was a low blow. Your primary care doctor is probably a good doctor, even though he's your former primary care doctor. Primary care doctors are not good at neurology. I learned in medical school and into residency and into training that once, if you're not a neurologist, you don't want to have anything to do with neurology problems. Internal medicine doctors, hospitalists, primary care doctors really do not like taking care of neurology. There's something in their brain that just shuts down when it's a neurological problem. They instantly call us and they want us to figure out what the problem is. They do not like neurology. Neurologists are a special breed of people. We are odd people. We like this stuff for some reason, but nobody else in the medical field does. So don't blame your primary care doctor. He doesn't like this stuff or she doesn't like this stuff. They're not good at this stuff, period. The idea that everybody develops dementia with Parkinson's disease is not true. Again, a lot do. He's not wrong. It is possible. And 15 years is a long time to have Parkinson's disease. And so it is not uncommon for people with Parkinson's disease who have had it for that long to develop memory problems, thinking problems, and sometimes progress to dementia. It's not a guarantee, though. Not everybody with Parkinson's disease gets dementia, at least not in my opinion. I have plenty of patients that have been dealing with this for longer than 15 years that are still probably thinking better than I am. And so that is not a guarantee. Is it possible? Yes. The longer you have the disease, is it more likely? Yes. Dementia also comes with aging. So the longer you have Parkinson's disease, the older you are, the more likely you are to develop memory problems, thinking problems, dementia. But my short answer to that question is I don't think anybody can look at anybody and say in 15 years you're going to have dementia. That's silly and not helpful at all. And so I would only take that with a grain of salt. And I don't necessarily blame your PCP. It's not his fault. He's just not very good at neurology. I'm considering teaching a water dance class at the YMCA for people with movement issues and general members. Water is good. So a lot of my patients have joint problems, and a lot of them actually, in fact, 2 people today told me that they did better with water therapy than any other exercise. And so I think water exercise is a great thing, particularly for people who have joint problems, bad knees, bad hips, bad backs, things like that. And so at the end of the day, I think it's a great idea. Yeah, and again, going back to the medical marijuana talk, sometimes you do end up paying people a lot of money for not a lot of good information. You really, my opinion is that the people who know the most are the ones at the dispensaries, and so that's really who you should get the majority of your information. But you always have to keep in mind that those people are hired by the dispensaries, and so they are there to sell you something. They are there to make sure you buy the product. That's how they make money. Not that it's bad information, but you have to keep that in mind. Everybody has an agenda. All right. My 80-year-old mother has Parkinsonism. How important / possible, I like the way that question is worded, is a regular sleep schedule for her? Important? Yes, for everybody's sake. So ideas for helping her and my dad to establish better sleep habits, because when sleep is disrupted, it disrupts the entire household. And the worst thing that happens is when you get nights and days mixed up. So you spend all your days asleep and then you're up all night, because that drives everybody in the house crazy. Nobody sleeps at that point and nobody's happy at that point. Following good sleep hygiene is important, meaning going to bed at the same time every day, getting up at the same time every day, minimizing TVs or screen or caffeine or exercise late in the evening. All of that is important. There's medicines we can do to help, but sleep habits, getting people to sleep on regular schedules is actually very difficult. Sometimes it's not possible. I've had patients where no matter what I do, I can't get them to sleep very well. And so at the end of the day, doing your best to maintain good sleep schedule is important for you and her and her husband or your dad, because otherwise everybody's tired, everybody's miserable, everybody's grumpy, and it really doesn't make for a good situation. But that being said, it is easier said than done. As usual, the key to success is bringing that up to your doctor, talking about what works and what doesn't, see if there's anything else that can be done to see if that would help. I'm going to skip that for a second. I have heard of the book, although I haven't read the book, Fighting Parkinson's Disease and Winning. I will get to that website at some point because I want to see if there's anything interesting. If there's something that I should know or there's some magic cure out there, please don't keep it to yourself. I think everybody on the call would like to know. How do I distinguish between Parkinson's disease and cortical basal degeneration? Or how do I just diagnose somebody with cortical basal degeneration? And really, to expand on this, what are the Parkinson's plus conditions? So Parkinson's disease is a collection of symptoms diagnosed by motor symptoms: tremor, stiffness, slowness of movement, balance problems. It's not the only thing that gives you those problems. There are other conditions that can give you those same symptoms, and several of them are called Parkinson's plus conditions, which means they not only have those symptoms, but they start developing other symptoms, hence the plus. And cortical basal degeneration or cortical basal ganglionic degeneration or cortical basal syndrome, yes, I know these are all really long names, is one of the Parkinson's plus conditions. Progressive supranuclear palsy, multiple systems atrophy, and diffuse Lewy body disease are the other kind of common or ones that we think about most in terms of Parkinson's plus conditions. But cortical basal syndrome, I diagnose when symptoms are really, really predominantly one-sided. So everybody with Parkinson's disease starts on one side, usually. And then within a year, 2 years, it spreads to the other side, or at some point it spreads to the other side. The telltale sign of cortical basal syndrome or cortical basal degeneration is that it stays really, really much more worse on one side than the other side, almost to the point where they lose control over a limb, or they develop what's called apraxia, which is a loss of a learned motor skill, meaning they could do something with one side, strike a match, put on lip gloss, comb their hair. They cannot do it with the other side. That's apraxia. And those are the things that really point you down the diagnosis of cortical basal syndrome or some other atypical Parkinsonism or Parkinson's plus condition. And so at the end of the day, there's a lot more to it, but that's kind of the quick and dirty or the short explanation for the distinction between a Parkinson's disease or some of these other Parkinson's-like conditions. Roundup, thank you. I don't know why I couldn't come up with Roundup. That's the pesticide that's in the news that's leukemia and Parkinson's disease and everything else. Are hair dyes, bleaches associated with Parkinson's disease at all? Not that I've heard of, although I know in hair dyes there's a lot of sulfites. They're probably not good. I mean, take it from somebody who doesn't have a lot of hair, so I'm not the hair expert by any means, but the little that I do know about dyeing your hair is it's kind of toxic to your hair. Your hair sits right on top of your scalp, which sits right on top of your skull, which does eventually lead to your brain. That's a lot of layers to get through. So I think it's a little bit of a stretch to say that it leaches down into your brain, but it's probably not good in general. Do I know that it's been associated with Parkinson's disease? Not that I've seen or that I've heard, but I also wouldn't be surprised if somebody's doing a study on that. Okay, I still don't, so going back to the lead levels in your blood versus external inducement. I mean, as far as I know, most of lead toxicity or lead problems come from external sources. So again, that would be an external or environmental trigger or environmental factor that could lead to a neurodegenerative condition, but it's a little bit tough to say. Am I currently involved in any clinical trial? I'm involved in two ongoing research trials right now. One is just about to close. That's a DBS study. In fact, it might have closed. And the other one is actually a prospective look at people with Parkinson's disease and how they progress over time. But that one is not enrolling anymore either. So I'm not involved in any active enrolling studies. The best place to go for research studies is really the Michael J. Fox Foundation, or somewhere where they can really tell you what's going on. And I highly recommend that if you are able and capable, we need as many people to participate in research trials as we can get, because that's how we advance the field. At some point, I plan to be more involved in research because I really do want to help, progress the field. It just hasn't fit into the schedule. And unfortunately, if you know anything about the current state of affairs in medicine, it's bad. You know, having enough people to accomplish anything is really, really tricky. We don't have enough of anybody. And so research is one of those things that has definitely taken a hit because of lack of people. Not patients, I mean staff. Is there a link between vertigo, tinnitus, and Parkinson's disease? There might be. Not that I've ever seen, not that I've ever researched or read about in a journal, but I have a lot of patients with Parkinson's disease that do end up with ringing in their ears. And again, we do know there's a relationship between vertigo and tinnitus. Again, this is an inner ear apparatus problem. Generally, when we think about true vertigo or benign positional vertigo, it's a crystal problem in your inner ear, and they get thrown out of whack. And that can definitely lead to ringing in the ears, which is the fancy word is tinnitus. And I've had a good amount of Parkinson's disease patients have that. So I have to assume there's some sort of link there. I'm just not entirely sure where it is. And I can't say that I've read any papers on a link between the two or looking at that specifically. So I'm going to go out and say, yeah, I think there probably is, but I'm not sure. What can be done to stop somebody from getting up in the middle of the night and getting into things, rearranging things, making a mess in the kitchen? That's a tough problem. So punding is something that happens in Parkinson's disease where they kind of like pull out a bunch of stuff, but don't actually accomplish things. Impulse control problems goes with the medicines that we use for Parkinson's disease. So that can lead to binge eating and things like that. And it's a hard problem to try to work on. And so problem number one would be trying to figure out, is this a side effect of the medicine, or is this just more of a nighttime sleep disorder? If it's a side effect of the medicine, then maybe you can get away with trying to decrease the medicine to see if that would help. If it's a true sleep problem, then maybe we have to think about other things, linking it or likening it to REM behavior sleep disorder, where I will use melatonin or Klonopin to try to help calm down that active sleep, that acting out dreams. Maybe that would be a strategy. Or maybe at the end of the day, if it really is truly during sleep, then getting you to a sleep specialist might be the next best choice. Have I heard of the Happy Healthy Brain Foundation and the WAVY? It's being developed to better recover from concussion. I was going to say, I thought I heard about something from that in concussion, but I hadn't looked at it or heard of it in Parkinson's disease. It'd be interesting if we could use something like that to monitor the effectiveness of medicines or TBS. I think you have the making of a hypothesis for a research trial there, but that's probably easier said than done. I will also add this to the list of websites that I will go to and try to look stuff up and get back to you a little bit later, but I haven't heard of any look at that in terms of Parkinson's disease. And with that, I just got to David's, my battery just died and the charger is apparently not working. So apparently he left us. And it happens to be that I'm right on time. Now, I didn't do that on purpose, but at the end of the day, hey, I'll take it. So a lot of good questions there. A lot of good questions about, medical marijuana, which is still a topic of discussion because, believe it or not, it's still federally illegal. It's still Schedule 1 federally, which ranks it up there with heroin and cocaine. Although state by state, it is legal. What that means, I don't know. But there's a lot of research, I think, to be done there. And there's a lot of good questions about these things that are really still have a large room to be looked into. And that's the one good thing about where I'm at now is that with Parkinson's disease, there's so much that we still have to learn. There's so much that we still have to do. That research is just ever increasing and ever continuing to hopefully get us closer to the Holy Grail. That's a good question for everybody else. Is anybody else using modified tools at home to help with eating or writing? I can't say that I've had a lot of success. I've had some people use that anti-tremor silverware without much success. There are some tremor devices, but I've never been able to get any of them for any of my patients. And so I'm not a great person, but maybe somebody else will have an answer for that. And with that, Casey, I'm going to stop talking.
Getting an apparatus or a device called SteadyWear. You wear like gloves. It just hasn't arrived yet. I think they're backed up on their orders, but we'll let everybody know when it comes, and you're welcome to come and try it out. And
the problem that I've had with stuff like that and the Calitrio and a few other devices is I can't get them paid through insurance, and they cost an
Mm.
arm and a leg. And so I've never actually had a patient get one so I could see it in action. And so again, if anybody gets one, or if anybody has some experience with them, let us know, because I'm always interested in what else we can do.
Well, we'll let everybody know when it arrives, and if you want to come out and give it a try, and we can bring it to your clinic too for folks to try out.
Way I can play with it and try not to break it.
You can come, yes, and you can come visit us and try it.
Sounds like a plan. I will let you know.
My battery's about to go again, so I'm gonna split.
And I'm going to call it a day too. I will tell you more about my DBS research next time, but it's basically showed that it worked. But I'll talk more about that next time if we want. Go ahead, Casey. It's all you.
Okay. Well, thank you, Dr. Leichliter and David and everyone for joining in, which is amazing. As always, it's a wonderful community. I'm always learning myself.